Hello and welcome to the Digital Health Hubcast, where technology and healthcare collide. I'm your host Hannah Clemmens from the South Yorkshire Digital Health Hub, where we're on a mission to tackle health inequalities by transforming the future of digital health. Digital innovation is at the heart of the future of healthcare. And on this podcast, I sit down with leading experts and innovators from across the digital health landscape to discuss the biggest opportunities, toughest challenges, and how we can innovate in this space to create a healthier and more connected future. NHS England defines health inequalities as unfair and avoidable differences in health across the population and between different groups within society. These differences include the place we live, our level of education, our income, what our social support network looks like. These wider determinants of health are often interlinked and can account for around 80% of our health. In South Yorkshire, health inequality is stark. Life expectancy can differ by as much as 20 years between the richest and poorest neighbourhoods of Sheffield. There is already lots of brilliant work going on in Yorkshire to start to tackle these inequalities, including some of the work here at the South Yorkshire Digital Health Hub. While digital technology has great potential to enhance healthcare, it also risks deepening inequalities between those that can and can't access this technology. So how can digital health innovations ensure this doesn't happen? How can we learn from what has and hasn't worked well in the past? To answer these questions, I'm speaking with Adele Bunch and Laura Boyd from Health Innovation Yorkshire and Humber, one of 15 health innovation networks that develop projects, programmes and initiatives to reflect the diversity and healthcare challenges of the local region. So welcome Adele and Laura, it's lovely to have you here today. How are you both doing?
Good, thanks. Hannah, how are you?
Good. Oh, I'm all right, thanks. Laura, how about yourself?
I'm good, especially as the sun is streaming through the window, so it finally feels like spring is here.
Oh
So
yeah,
yes, very happy.
it's on the way. It's a lovely sunny day here in Yorkshire. So we're here today to talk a little bit about health inequalities and how that might impact work in digital health innovation. But before we get into that, I was wondering if you could tell us a little bit more about the work you're doing at Health Innovation Yorkshire and Humber. Laura, I'll start with you. Why don't you begin?
Oh, thanks, Hannah. So I'm relatively new to Health Innovation Yorkshire and Humber. I just joined in October. And my role here is Director of Digital Partnerships. And the role description was very much around how can we really make the most of our digital and our data assets to have a better or a greater impact on patient health, but also I think the well-being and the impact that our NHS colleagues can have in their place of work. So inequalities really gets to the heart of that, doesn't it? When we look at the populations across Yorkshire and Humber, the breadth of differences that we see in terms of our different communities, our different populations, from urban to coastal to very rural, like where I live now, there's a real breadth of different experiences people are having day in, day out. So I really feel for my role to have an impact, we really need to get to the heart of that and think about how digital and data can complement that. So that's absolutely a passion of mine. As I said, I'm quite new, and before this I was at UCL Partners, where I worked on two programs, one a cardiovascular disease program, and again, cardiovascular disease really is a disease of inequalities. We know if you're living in our more deprived communities, you're up to 5 times more likely to die from a heart attack or stroke. And in the 21st century, it seems to me absolutely unacceptable that we still have that disparity. So I'm really passionate about, what we do in our day-to-day work to make an impact. And I realise I haven't actually answered your question, which is what are we doing at Health Innovation Yorkshire and Humber? And that's because to a degree, I'm still working with ICB colleagues to understand, where this role might have the biggest impact. But one of the things I'm sure we'll talk about, because everyone's talking about it, is AI and what that might mean for us. So maybe we can come back to that, but I'll hand over to Adele.
Oh, thanks so much, Laura. Yeah, Adele, let's hear from you.
Thanks, Hannah. So my work at Health Innovation Yorkshire and Humber, it might be helpful if I just give a little bit of an overview as to what the Health Innovation Network is. So we're a network of 15. We've got us in Health Innovation Yorkshire and Humber, and then there's 14 other dotted across England. And we've been around for about 10 years now. And ultimately, we act as the innovation arm of the NHS and the honest broker between healthcare and industry. So we've been funded for some of our activity by NHS England and the Office of Life Sciences, but also we attract project activity supporting research and in the real world evaluation of innovation ahead of that wider adoption and scale. And we're really passionate about health equity and health inequalities, and really seek to level up the region, encouraging more investment into the region, but then looking after our population in terms of their health and their work.
Fantastic. Oh, thanks both. That's really, really helpful, just to frame where we are to start with. Let's talk more about that last point then, Adele. So part of the work that you're doing is supporting initiatives that reduce or trying to reduce healthcare inequalities. Can you tell me a little bit more about this kind of work, perhaps with some examples?
Yeah, so on behalf of NHS England, we work with our other 14 health innovation networks to lead the Innovation for Healthcare Inequalities programme, that's abbreviated INHIP, and that targets the core 20 lowest IMD of the population across those multiple clinical areas in both the adult and the children parts of core 20 plus 5. And that's all designed to improve access, experience and outcomes. So as part of that project, we've been working with clinicians, VCSE organisations, including the physical activity sector and charities. And we've managed to really reach underserved and underdiagnosed communities, bringing health checks to those people in their settings, supporting wider diagnosis of cardiovascular disease and asthma, and then ensuring that those people are on the correct pathway. With our North East and North Cumbria Health Innovation Network, we co-run a community of practice, a health literacy community of practice, and that brings together health and care professionals and innovators in this space to discuss and learn about all things health literacy, including digital interventions. And then one of the pieces of work that I'm really proud of is a piece that our workstream lead Harriet Smith led with a lovely Dr. Lenos Jones, a respiratory consultant at Mid Yorkshire Hospitals, and that was around her straight talking project. And I believe this resulted because one of Dr. Lenos's patients was spraying her asthma medication on her cat. That patient didn't understand her asthma condition or what the medications were for. So the team quickly developed a series of really innovative, multilingual, multimedia, culturally sensitive, targeted resources for patients with poor literacy, health literacy, to really help them understand how they can manage, self-manage their condition. That included some YouTube videos and leaflets and avatars and like QR codes on posters, which really helped address the gap in explaining asthma self-care to people who English just isn't the first language. And those materials have since made way out of the UK and internationally. And I'm pleased to say that the project was nominated for a Patient Health Service Journal Partnership Award, the most impactful project addressing health inequality. So, it's gone really far in helping to narrow health inequalities.
Wow, that's brilliant. What a great story.
It's an amazing story. I hadn't heard it gone international. That's absolutely fantastic. Hats off to you and Harriet, Adele. That's amazing.
It wasn't me, it was Harriet. It was all Harriet and Dr. Lenos Jones. I was able to attend the HSJ, but honestly, it's they did it all, not me.
Yeah, that's brilliant.
I was just going to come in and compliment the answer. So Adele talked about how we bridge that gap between kind of research industry and the NHS. So one of the other things we're doing is really working with some of the small companies and in some cases industry to think about how we tackle health inequalities. We run something called Digital North with the other HINs, or Health Innovation Networks, across the north. One of the innovations we supported last year was called PocDoc, which is a point of care testing for cholesterol testing, and that really enables you to go into communities to test for lipids for high cholesterol, and it really removes that barrier, because normally if you need a cholesterol test, you've got to go into a healthcare setting, which means making an appointment, navigating how to do that, going in, having a blood test, waiting for results. Whereas PocDoc has been able to kind of get into the heart of communities, and I think they've done a huge amount of work in some of our communities, particularly in Bradford, with non-speaking members of the community, particularly women who are less likely to come forward for cholesterol streaming. So just an example of how we work with the NHS, but also with industry, to think about how they are tackling and not exacerbating health inequalities.
So it sounds like a common thread then to all those projects you've spoken about is the importance of taking the service to communities. Is that right?
Yeah, I think that we've got lots of underserved communities in Yorkshire and Humber, Gypsy and Roma traveller populations, some of your ethnic minority communities that just don't typically engage with healthcare. And in Bradford, for example, we have the Bradford community-led health checks project that we supported, and they had noticed that they had really high prevalence of younger men attending A&E with CVD events, so like heart issues and stroke. And with their Born in Bradford data, they did some work and decided to offer community-led health checks in mosques. So they took those professionals, they took those consumables, carried out those checks, and fostered really good relationships with the community leaders, who then advertised the events and brought sometimes people coming from out of area. They had people as far as Manchester come because people couldn't get in with their GP. And they were able to, and I don't know the stats off the top of my head. I think we published it in our last impact report, but really, really high levels of cardiovascular disease, amongst those checked people who are now on the right pathways and receiving the treatment that they need. So brilliant intervention.
It is a brilliant intervention. I guess going back to your question, is it about taking services out to communities in need? In many cases, that is the solution. But I guess what we try and do at the Health Innovation Network is really start with the need. What's the challenge? What's the problem? And where, if appropriate, could digital health or digital tools or technology play a role in solving that challenge? So we really try and kind of start with the need, and then see where the data digital might be able to support that. I think we can all think of examples where there's been some really great, lovely, shiny tech, but it's sat on a shelf because although it looked really pretty, it didn't really meet a real need, and therefore it never really got going.
Yeah, and this is something that we've been speaking about quite a lot at the Digital Health Hub, is the importance of involving users from the very start. So I wonder if you could both talk a little bit more about how, or the importance of involving people throughout the whole kind of design process and the whole innovation journey, and what difference that makes.
So patient involvement is a really fantastic way to really get under the skin of the challenges and barriers that patients face when navigating health and care. And, by involving people right from the beginning, innovative solutions can be co-produced, and specific to digital can ensure that users are given the necessary support and training to ensure that they can understand and use any new digital technology. The Straight Talking project I mentioned earlier, that was co-developed and co-produced with people who needed those digital assets to really understand and navigate their own condition. And I think another example is the work that we're doing with the National Pathology Imaging Cooperative, NPIC. And they have a patient involvement function that our colleague Graham Presswich leads, where there's 18 members of their patient and public involvement advisory group. And those people, they bring a wealth of experience and opinion to this open forum that meets fairly regularly, and that discusses and shapes all of NPIC's projects and products. So anything that NPIC is changing or doing differently, they run it through their PPAG. I think as well, patients and the public, they really need to feel safe when using digital technology. So they need to understand what it is they're using, and if any of their data is being, tracked, and how that might be used. So I think it's really important to bring people on a journey with you from the outset, where they can really understand why things are changing, and for the good of advancing health outcomes. You then have advocates within that patient group who can encourage their peers to get on board with the digital transformation and the interventions too.
Yeah, just drawn. So a previous role was managing the NHS Innovation Accelerator, and that's a national programme that supports evidence-based innovations, or innovations that show promise to spread across the NHS. And there are a couple that really struck out with me from the kind of the early days and the first couple of rounds. One is an innovation called Sleepio. And that was developed by a guy called Peter, who had chronic insomnia, and he couldn't get to sleep. And it, as anyone who's had insomnia knows, it has a massive detrimental impact on your life. He was lucky and he got cognitive behavioural therapy in person. But he said, well, why can't we put this online? Why can't we make this digital so that it really democratises that aspect of health services? How can we get more people accessing something that I've had the luxury of benefiting, so more people get access to it? And that led to the creation of Sleepio. And I've always thought it was a really interesting, needs-led innovation developed by someone who was suffering from this condition. But also that concept of how we democratise health, how do we get services, more quickly into the hands of others. The other thing that struck me much more recently is I've been working on the cardiovascular disease stuff, and we've spent a lot of time in my previous role thinking about data. So how do we give primary care teams the right data so they know more about their patients who are at highest risk from cardiovascular disease? And we've developed various tools which could help them find those patients. But ultimately, it's all very well, isn't it, having a snazzy data tool, but unless something happens as a result of finding that patient who lives in, your most deprived part of wherever, and has limited access to a pharmacy, unless you can do something, nothing, it's kind of meaningless. So for me, it's not just the digital and the data, it's the so what, which comes with it all, the how do we support staff to be able to deal with the impact of a digital tool? How do we support patients to understand why they might be being contacted by the GP? So I just want to give this really amazing example, which was from Battersea. There's an estate called the Alton Estate. I think it's the second biggest council estate in Europe. And it's a part of Roehampton, and it featured on the news quite a lot during COVID because there was a real concern about residents not being able to access healthcare during that time. And Farwa, the clinical lead, wanted to adopt this tool we developed and put in a funding request and got access to it. And she did two amazing things. One, she really went out to her local population and said, we're worried about your health and we've gone out and got some funding and we want to share this with you, and isn't it fantastic? Come in and make the most of it. And the second thing she did was on the tool, it's called CBD Action, you can segment by people living in the most deprived community. So they started with people in the poorest decile and contact those patients. But instead of just doing the normal, I don't know, however messages you get from AccuRx, they increased that number, that frequency of messaging, and the number of times they tried to contact people, because they knew people were working shifts and therefore weren't picking up messages, like a 9-to-5 worker might do. And so I thought that was a really interesting way, celebrating why they were doing something a bit different, and then making sure that there was an appropriate response in response to the data that they had.
So were they calling to kind of say, come in for a health check? What was happening there? Tell me a bit more.
Yeah, they were calling to say, we can see that, for example, your blood pressure reading at its last reading was very high, and we can see it's time for a review, so please do come in. And they spent a lot of time thinking about not just, come in, but thinking about how they trained their staff to be able to have a real conversation about what mattered to the patient, why it was important to come in, how to make it easier for them. So they really focused on engaging some of the workforce who had an interest in motivational interviewing, and where they didn't have that in place, provided some extra training and some training on how to talk about those kind of wider prevention, lifestyle intervention. So it was a kind of a holistic approach to those conversations.
I see, that makes sense. Yeah. Oh, that's wonderful.
Can I come in, Hannah, on
Yes,
something
please.
that we've recently developed that can really bring patient and public involvement into the heart of innovation? More, not so much the development of it, but when it's ready and it's about to go in, and this can include digital. So we were commissioned by the Accelerated Access Collaborative a while back now to develop a patient insight framework. It was deemed that the uptake of NICE approved tech probably wasn't happening at the rate that they would have liked it. It wasn't happening quick enough. And they felt, the AAC, the Accelerated Access Collaborative, that there was a gap in that there wasn't a mechanism to routinely capture patient insight as part of spread and adoption plans. So we developed a framework that we developed with patients. We interviewed 29 patients who had been on pathways related to our medtech funding mandate, or what was the rapid uptake programme. And Graham and a colleague, Natalie Wong, at Health Innovation Yorkshire and Humber, they interviewed these patients and they wanted to understand the different patient touch points in the pathway and the challenges, barriers, and also the opportunities and the some of the good stuff as well when you deliver in med tech. And from that, we developed this framework and an accompanying report, and ultimately it supports anybody involved in rolling out innovation, so innovators, clinicians, any system partner, but putting patients right at the middle of those spread and adoption plans, so that right at the beginning of rollout, you're finding out what already exists around the patient voice, but what more do we need to do to ensure that it informs the successful rollout of this innovation.
Yeah, that's brilliant. And I think I love that framework. That makes a lot of sense, doesn't it? To put your user, your patient, right at the very start, right at the very middle, so that they can inform everything that happens. Like you say, there's so many examples of digital technology that just sits unused because it doesn't actually fit for purpose, or it doesn't actually solve a problem. Let's talk a little bit more about digital then. So we've said before that the shift towards digital, while it is necessary and important to, improve access to healthcare and realise better health outcomes, there comes a risk that those without access or without confidence to use digital technologies are left behind. So could you speak a little bit more about how this can be prevented?
Yeah, so I think we know the challenges people face. Affordability of Wi-Fi, affordability of mobile phone tech, and then that low digital literacy ability. And that can really hinder somebody's ability to access and understand a digital intervention. So I think there's a few key things that, we can collectively do when navigating this. And I guess the first is coming back to, understanding through authentic patient involvement who is excluded and the reasons why. You might have somebody who's really digitally capable, but in their native language. So if the app or the tech doesn't come with instructions or information in their spoken or written language, then it's not going to work for them. I think it's really important to co-design your services with the people that will be using them, or indeed their family and carers. And I think it's really important to work with partner organisations who might be able to offer support and signpost to further help. For example, we've been doing some work with Virgin Media O2, and they can give out free SIM cards and things. So there's different ways to support people. And then I think it's really important that when you're creating a digital intervention, what about those people that might need information in a bit of a different a different method? So what can complement that digital package? So maybe posters, leaflets, and remember, be really inclusive with your language so that you can meet the diverse needs of our communities. And sometimes it's being a little bit old-fashioned and reverting back to a phone call or offering a personal, drop-in session to ensure that all bases are covered.
Just building on that, I think if we hold in our mind that the digital piece is the enabler to great healthcare and delivery rather than the end in itself, I think that's what I try to hold in my mind. I think that helps us navigate some of the kind of concerns about people being left behind. No one should be left behind. If it's appropriate to use some kind of digital solution, that's fantastic. But if it's not, then it's not an enabler. It's not working. Therefore, we need to look at what else is in place. A couple of things struck me as Adele was talking, and it'd be great to know, Adele, your perspective. We should talk more about these things, but I've always been shocked over the last few years about when you ask any digital SME, oh, is this available in a different language? The answer's like, no. And somebody last week said, well, it is, but we still need millions of people really to go and check what our work. And I just thought, well, no one's going to have the time or the resource of the NHS to do that, so it's not going to work. We need to get better at the kind of the language, the accessibility piece. You talked about digital literacy earlier, and or health literacy, making sure that people understand, if it's the asthma inhaler, where that's being used, not on the cat, or if it's, whatever there's some great examples of where it's not as obvious as it should be. How do we support people to do that? So that's one piece. And the second is just that real hand-holding. Unless something's easy and intuitive to do, no one's going to do it, are they? Whether they're a professional at work or whether they're at home looking after their health. And in my previous role, again, we really tried to think about how could we use a Fitbit to help people manage their blood pressure with an app and a device and a blood pressure monitor. And just as I'm rolling off all this tech that we were trying to chuck at someone, you can tell why this project never got off the ground, because it was too complicated. There were too many bits that we're trying to plug in, let alone before we got into the kind of how do we plug this into a primary care network. So, just some reflections.
Yeah, thanks, Laura. And it sounds like, coming back to your first point you made about things not necessarily being accessible if they're not in the languages that your users are going to need. I suppose a part of this would come from making sure that you have a diverse user base that's working with you with the co-design. And I wonder if you could speak any more on how innovators could ensure that they do get a diverse kind of range of people to start with. I think you typically see in a lot of patient and public involvement and engagement groups, especially in research, they're usually people who have an interest in health anyway, or might have a background in health, and they're kind of involved in lots and lots of different groups, and they might all be the same demographic. So can you speak any more on how we can ensure that when I am co-designing for my new innovation, that I make sure that I'm speaking to a range of people so I can get that range of needs?
I think it's but working with your trusted VCSE organisations who are already trusted in their communities and really docked in. And I think through them and through that trust through them, that's how you can reach that much wider pool of people.
Yeah, so that's a voluntary community social enterprise, is that right, VCSE? Yeah.
VCSE, yeah.
But thanks.
Yeah, as in finding representatives from the communities you want to reach, you might not naturally be able to kind of access. So definitely agree on the VCSE. I think, as you say, it is hard, isn't it? Because the people who come forward are the people who have that predisposed interest in health, and probably the time and the financial stability to be able to give up time in the middle of the day when others might be at work, or caring responsibilities and so on. So thinking creatively, I think, is really important, whether that's through the VCSE or other ways. Again, in my last role, we engaged with a local school, A-level students who were thinking about what a future career might be, and we wanted to get them involved in some of our work. And I can't tell you how amazing these students were. Many of them were from minority ethnic, ethnicity backgrounds. So people at home weren't speaking English as their first language, and they went home and they tested these programs. And some of them were point of care testing for cholesterol in pharmacies. Others, I think there was an obesity project. But they went out to the communities and really got feedback. One group went and spent a whole day, I think, hanging out in the local corner shop, testing materials and ideas on people. They even translated videos into different languages for us. It was just incredible. But I did think there are innovative ways we can engage in different ways. But it does take time. We can't get away from that. And it does take funding, because we need to reimburse people for giving up their time. Otherwise, it's not fair, and it's exclusionary, because not everyone can give up their time. So I think we do need to think sensibly about how we make sure there is that funding and that resource and time available to be able to do this.
Yeah, that's a really important point. And I love that out-the-box thinking that you've described there. That's excellent.
Well, I think it's such an opportunity. I mean, it really should be an opportunity. But I'm always the optimist. But, there are so many examples of where, digital health is accessing communities or groups that we just didn't know about. The NHS England app team told me recently that women from, groups who just generally don't come forward for screening are now coming forward for screening because they're engaging through the app. And it's just, that's how digital is working as an enabler, delivering what we want. It doesn't need to stop other offline methods of engagement. It doesn't need to stop more traditional forms, but it's enabling better reach and access. And I think if we can build on examples of that, I think that's absolutely fantastic.
Yeah, so that's a great success story, and I think you're saying it's a lot about choice as well. It's not about forcing digital on anyone. It's about using it as a conduit to bringing people into or getting that service to that person, but still having the option of face to face or over the phone or whatever other option was available. Is that what you mean?
Yeah, definitely.
Yeah, thanks, Laura. Adele, do you have anything more?
No, I think just on that last point, absolutely, people are different and they have different needs and wants, and what might work for one person might not for another. So I think, yes, we need to bring our populations and communities on board with this digital transformation, but just remember that, it's not for everyone. And as long as we've got other methods of providing information and getting information, then we can have something that works for all.
I guess the last thing I probably just comment on is our own workforce. I mean, I've only been in this role 5-6 months now, but the rate of change has been incredible. I have a standard slide deck, but already it needs to change, because the rate at which new technologies, AI is coming through the door, it's really hard to keep up with. So we are thinking seriously now about how do we support NHS colleagues, the NHS workforce, and that's been reflected in the government publications over the last couple of weeks. How do we invest in workforce to be able to keep up with the rate of change? So we almost need to be quite forgiving on ourselves and our colleagues as to how do we keep a pace of this? How do we implement it safely? How do we make sure we're confident in adopting all this great stuff that's coming through?
Yeah. So supporting healthcare professionals, for example, to utilise all of these new technologies that are coming through.
Yeah, exactly.
Yeah. Oh, amazing.
And I think we did some of that, Laura, didn't we? In the West Yorkshire Innovation Hub with the Digital Primary Care Hub, I want to say it's called, but
the Digital Ambassadors Programme.
Yeah.
Which is now regional. So it's now been taken up across the whole of North East, North Coast and Yorkshire and Humber. So great programme. I think they support about 70 people a year. So definitely recommend it for anyone who's interested. we can post a note in the podcast links after.
Sounds good. Links incoming. Amazing. Well, thanks so much, Adele and Laura, for coming and sharing your insights in health inequalities and digital health. I've certainly had a good time. So thanks so much for sharing.
Thanks, Hannah.
That was Adele Bunch and Laura Boyd from Health Innovation Yorkshire and Humber, speaking on how innovation with patients at the centre can be a powerful force for tackling health inequalities. From creating asthma guidance in multiple languages to cholesterol checks in local mosques, their work shows that change happens when we meet people where they are. With advances in technology, it's important that healthcare professionals and patients are well supported so that they can get the most out of these tools, and that any new technology acts as an enabler of better care rather than replacing any services. You can find more information about the Health Innovation Networks in the links in the notes. Thanks so much for listening to the Digital Health Hubcast. I'll see you next time.